Good afternoon. I am Monica Pica with Sachs Healthcare, and I will be your technical producer for today's webinar. Firstly, on behalf of Stryker and Sachs Communications, we want to thank all of the frontline workers in our audience for your commitment and passion in helping all of us through this very, very difficult time. We are truly indebted to all of you. I also want to show our audience how you can send questions throughout the webinar. Please see the Q&A tab to the right of the player where the content-related questions can be entered, and our speaker will try to answer as many questions at the end of the presentation. And for technical assistance, please use the Tech Support tab directly to the right of Q&A. Our moderator is Rhonda Turner. Currently, Rhonda is the Nurse Operations Support Specialist focusing on the medical surgical service line, specifically education, onboarding, and leadership at Banner Health. SPHM and fall prevention has been a large part of her life and has inspired her to become involved as a leader in her facility, region, system, national, and international levels. She is an active ASPHP board member since 2019, and Rhonda has been an integral part of the trends nationally and internationally with SPHM, fall prevention, caring for patients of size, and early mobility. Welcome, Rhonda.
Thank you so much, Monica, for that kind introduction. As you said, the title of today's webinar is Practical Approaches for Managing the Care of Patients with Obesity. We have two exceptional speakers today, Susan Gallagher and Cheryl Holsworth. So welcome. Dr. Gallagher is certified in bariatric nursing and is a certified safe patient handling professional. She is immediate past president of the Association for Safe Patient Handling Professionals and associate editor for the Journal Workplace of Health and Safety. Dr. Gallagher also serves on a number of international boards and is a recognized speaker on skin and wound care, outcomes, bariatrics, ethics, risk and loss control across the globe. She is the author of more than 200 peer-reviewed articles in nearly 20 book chapters and books. Ms. Holsworth is a senior nurse specialist in bariatric surgery at Sharp Healthcare in San Diego. In this position, Ms. Holsworth serves as the clinical expert for the nursing staff for bariatric surgery patients. She is active in several nursing and professional bariatric associations. Ms. Holsworth has presented posters and lectures at numerous medical conferences and has published on the topic of managing obesity in critically ill patients. The speakers do not disclose any relevant financial conflicts of interest associated with this presentation. Continuing education for nurses and respiratory therapists. This is approved for one contact hour. This is very important. You'll get a link to obtain your certificate of completion at the end of this presentation. Please see the accreditation statement below. And again, we'd like to thank Stryker, one of our vendors, for this educational activity and their support. At this time, I'd like to turn the presentation over to our first speaker, my friend and colleague, Dr. Susan Gallagher.
Thank you very much, Rhonda. It is a privilege to be here. Cheryl and I welcome you to the presentation titled Practical Approaches for Managing the Care of Patients with Obesity. So the objectives of this course are to describe the evolving demographics of obesity globally, within the U.S. in general, and then review the demographics of obesity among age groups, gender, and regions. We plan to define the meaning of the term adiposity-based chronic disease, which is commonly referred to as ABCD. This term better captures the relationship between excess adiposity and chronic disease as it impacts the individual. We'll be talking about the hazards of immobility, and I'll have the opportunity to touch on the topics of the skin and falls as it relates to immobility. Cheryl will talk about metabolic weight loss surgery, or weight loss surgery, as it's sometimes called, and how it's been practiced in the U.S. for many decades. She'll talk about the criteria for weight loss surgery and how that has evolved based on a number of factors. And she'll explain the criteria for weight loss surgery currently in place in the States. We'll talk about sensitivity because sensitive care is essential in managing the clinical, economic, and humanistic outcomes associated with caring for individuals who have obesity. And sensitivity will be a common theme throughout our presentation today. We'll explore the science that supports the ongoing need to understand this sensitivity. And then we'll conclude with a case study that features a pre-plan for care, and within that, we'll talk about the 4 elements of a pre-planning tool. So how do we plan to do this? Let's look at the outline that Cheryl and I put together for you. So first we'll start with demographics, of course, the clinical issues. We'll talk about sensitivity throughout the presentation, talk a little bit about metabolic surgery, and then jump into pre-planning for care and how we do that. So what we'd like to do is start with a polling question. And so we'll go ahead and start the poll. And so let me ask you this question, and it really is your opinion, right? And that's what we're looking for. Which statements are true about the prevalence of obesity worldwide? And there are 3 responses that you can select. The first is there are more individuals today with obesity than those suffering from starvation. The second response that you may select is obesity is defined as BMI greater than 30 by most of the Western world. And the final selection is diabetes and obesity are on a parallel trajectory. So I'm going to go ahead and let you take a few minutes to complete these responses, and then we'll talk about that. All right, so as you're entering your responses, and I can see them here on the screen, it'll be interesting to see how each one of you looks at this a little bit differently. So I think we have a lot of responses. I'm sure that there are others of you who would like to include your answers. So we'll give this just about another 5 seconds or so, and then we'll close out the poll. And once I close it out, which I'm going to do right now, is you'll be able to see this data on your screen. And so what I'm seeing is that about 13% of you responded that there are more individuals with obesity than starvation now. And most of you responded to the definition of obesity as being defined as BMI greater than 30 by most of the Western world, and that is correct. And about 41% of you responded, about equal to the second item, that diabetes and obesity are on a parallel trajectory. So thank you very much for completing the poll for us. So let me just talk about this a little bit, because I think that I can say that many of you are saying, well, weren't all of those questions correct? And they were correct. And what I really was looking for is your opinion and kind of the way we understand the prevalence of obesity worldwide. So what I want to do right now is talk about measurement and definition, because measurement and definition are foundational to this discussion, and we will come back to this as we talk about pre-planning as we conclude this hour. But the value of measurement and definition is that we're all speaking the same language. And there are many ways to measure and define weight and weight distribution, but you see I've selected 4 that evidence suggests makes the most sense for us in healthcare settings. So when we look at body mass index, when we look at weight, we're really interested in weight as it aligns with the weight limits on the equipment that we have available for our patients, but that doesn't tell the whole story. Now, when we look at body mass index, and you see here the different criteria, there are some healthcare facilities that only use body mass index to identify those patients who are at risk or who require special accommodation. And usually that BMI is up above 50 or so. I mean, a person with a BMI 40 is categorically morbidly obese, but those individuals many times are very mobile, and their weight doesn't preclude their use of your standard equipment. The third criteria that many facilities use is what we call body width. And it really is the width of the body, not the girth, because what we're wanting to know is, does equipment accommodate the width of the person, or what we call the weight distribution, some call weight maldistribution. But what is the person at their widest point? And sometimes it's hip to hip, sometimes it's side lying, and sometimes it's feet to feet. And the fourth criteria has to do with mobility. And I included reference here to the BMAT, the Bedside Mobility Assessment Tool. If you haven't seen this, you can just look it up on the internet. It's really great. But it's a quick nursing assessment that gauges the patient's ability to participate in care in real time. So these are some elements of measurement and definition, and we'll come back to these in a little bit when we talk about our pre-planning tool. So let's look, so we've talked about measurement and definition, and now I want to talk about the evolving demographics of obesity and what this means to each one of you as healthcare workers. And I know many of you intend to use this information to provide your own training to your colleagues, so I want to share some data with you. The Centers for Disease Control have put in place a number of really creative ways to visually describe the evolving demographics of obesity. So I have two slide sets I want to share with you. The first is a downloadable set available for your use when you do not have internet access. And the second set I share with you is simply a link that you can share with your team. So let's take a look at that right now. So let's refer to that second bullet that you see on your screen. This link takes you to prevalence maps that look just like the screenshot that you see on your screen. And these can be used in your training to describe obesity among perhaps adults, certain high-risk ethnicities, certain regions within the country, and more. But today I'm going to share with you what's on that first bullet, and that's the 1985 to 2010 slide set, because it really pertains more to our conversation today. So before I open up the slide set and move us through it, there are a couple things I want to share with you. The data was collected, the first slide that you see, in fact, we can move to that now, collected data in 1985. So these are obesity trends among U.S. adults. And you can see those slides where there's no data are white. The slides where less than 10% of individuals had BMI greater than 30 are in the light blue, and then the medium blue are those who have BMI 30 or greater, 11 to 14%. So you know, this kind of sets it in context. So this is 1985. We're going to go through to 2010, and I want you to think about not only our patients evolving, but also healthcare workers as well. And we're going to talk about falls later on in the program. And I want to think about falls and center of gravity, et cetera, not only among our patients, but our healthcare workers as well. So we'll come back to that. The other thing I'm planning to do is to stop at 1997. In 1997, Tui Main did a study, and she indicated that the average RN, and I know not all of you are RNs, but this was her study, the average RN on an average shift lifted, turned, repositioned 1.8 tons. And some people want to, you know, when we talk about that data, say, well, of course, it's at least that much. And then others say, oh, that's a lot. And I think it just depends. But those were her findings. And so we're going to stop at 1997, and then we're going to progress to 2010. That's the last time data was reported in this way. We're in 2020 now. But it still tells us, or provides us with that message in terms of how much weight we're asking healthcare workers to lift, turn, reposition during their shifts. So I'm going to go ahead and get started, and like I said, these are available to you. This is 1985, so I'll move forward here. So, we're adding some new categories. You can see that. All of the states are collecting data at this point. And this is 1997, as I promised I would stop and look at. And you can see there's a new category of obesity in 1997. This is when the TWE main study was done, when we knew that we lifted, turned, repositioned 1.8 tons in an 8-hour shift. So now we're going to move forward to 2010, and this is where it gets interesting, new category. Now we're in 2005, new category. And so when we ask ourselves that question, why are we here today? We're here today because we are seeing increasing numbers of individuals in the general community. We're seeing increasing numbers of people in healthcare, receiving healthcare, and we're seeing increasing numbers of healthcare workers who are suffering from that disease of obesity. And that's what we're really going to talk about today, is what are strategies that can be done to accommodate this. So just real quickly, this is why we're here today. This is the first time in history when there have been more individuals suffering from the condition of obesity as compared to starvation. And this is not necessarily because there's adequate healthy food. Rather, the quality of our food is questionable. And even though there are many who are overweight, a lot of our patients are also malnourished, which is a problem in the States. Now, as far as the U.S., we see a higher degree, and you saw that in the maps, of obesity in the Southeast. However, obesity affects all ages, all ethnic groups, all socioeconomic groups. We do find recently that there's an increased severity of obesity among men, and there's an increased frequency among women. So now I'd like to talk about the cellular impact of obesity. And so I just need to say that there is a high degree of adiposity that affects every cell of the body. And that's because systems are comprised of organs and organs are comprised of cells. So you can see the impact of adiposity, you can see the impact adiposity has on every cell of the body. And for this reason, in 2009, the Endocrinology Association suggested the term obesity be updated to the term adiposity-based chronic disease. So let's talk about ABCD now and what it means to your patients and to you. So the disease of excess weight is associated with a number of adverse health conditions. And currently a number of professional organizations and professionals have suggested that the health consequences associated with obesity be described as this adiposity-based chronic disease. And so that's what we're talking about on this slide. The reason for this designation pertains to the impact of a hyperinflammatory state on health in general. Adiposity, especially that which is located in the abdominal region, which you see both of the individuals on the slides have abdominal adiposity. This leads to the release of the cytokines, the adipokines, other inflammatory markers that place the patient in this hyperinflammatory state. This state of sustained physiologic stress contributes to a number of comorbid conditions, and you can see those listed on your screen. So this is the reason why adiposity or obesity is being framed a little bit different as a chronic disease, and it makes sense. Now, the hazards of immobility associated with the person who is obese are profoundly serious and happen more quickly. Early, progressive, and ongoing mobility reduces the commonly recognized hazards of immobility in general. And shortly, I'll talk about skin and falls related to immobility. However, what we do know is that mobility tasks can be very time-consuming, Healthcare workers report a fear of personal injury and also a fear of patient falls or other kinds of injury. Now, you see a reference at the bottom of your slide, and in that reference there is a chapter specifically addressing the hazards of immobility, looking at a systems approach. But because we know adiposity impacts every cell, then we know it impacts every organ and every body system. What I want to do now is to talk about the skin, because I know many of you had questions about that, and so I want to address this. Skin injury among the obese person is different than the non-obese person. You know, generally pressure injury forms over a bony prominence, where there's external pressure from a mattress or another device that compresses against the bony prominence, and then it creates destruction of the soft tissue in between those two forces. Now, in the presence of obesity, pressure injury formation is different because the point of external pressure is not necessarily over a bony prominence. In my opinion, pressure injury generally occurs over the buttocks, not the sacrum, as this is often the point of contact with the mattress. Now, the other area of skin injury I want to talk about is intertriginous dermatitis, and that can occur within skin folds, and it can contribute, the weight of skin folds can contribute to pressure injury. It's different than intertriginous dermatitis, but it still is a contributing factor. And finally, we know that tubes and catheters exiting the body can burrow into soft tissue, and this leads to device-related pressure injury. And then I recognize I haven't talked about either incontinence-associated dermatitis or massive localized lymphedema. There's an all-new chapter on incontinence and obesity in the 2020 WOCN core curriculum. And if you're interested, I suggest that you refer to that chapter. Also, the slide that you see in front of you, the picture is from Dr. Caroline Fife, and I appreciate her work, and she has done phenomenal work on massive localized lymphedema, and I would refer you to her for more information about that. Now, before I go any further, I want to say that many individuals with obesity are overweight but undernourished, which can lead to compromised skin. The second thing I want to talk about is pulmonary compromise can threaten skin health. So a holistic approach to pressure injury prevention is really best, and it needs to be an approach that really includes the entire interdisciplinary team. Now, the next thing I want to talk about is falls. Obesity has a negative impact on balance and postural sway. Thereby, it increases the risk of functional limitations, and this can lead to falling. The second factor is that individuals who are older and also have obesity are at increased risk of falls. And this particular category of faller has a higher prevalence of pain and inactivity than those who do not have obesity. The second element I want to talk about in terms of falls has to do with the abdominal pannus. We know that there are 5 grades of panniculus, and you know that those are either a rounded belly all the way to a pannus that touches the floor. So there are 5 different grades. This throws off center of gravity. There was an article that I did many years ago that talked about the physical therapy elements and the WOC elements to management of the pannus and reimbursement to that end. I'm told that there's an article that just came out a few days ago around the pannus and care for the abdominal pannus, and that has prompted discussion around the grading of the pannus and risk of falling. Many clinicians are looking at the benefits of a low height in a bed frame from both a fall with injury prevention standpoint and to assist increasing mobility, as the height range of the bed frame can accommodate a wider range of patient heights. And the last thing I want to say about falls is to really ask this question: does your fall protocol have provision for the patient with either a maldistribution or excess weight? And so I would challenge each of you to think about that and to think about, is there an element of obesity in your fall protocol. So now I'll talk about barriers to care. And in a manuscript that came out yesterday as a pre-release, which you see referenced on the screen, we identified the barriers to care. And this is what we found, that there is extended hospitalization, there is a longer ICU length of stay, and there's difficulty in placing the person from an acute to a post-acute setting. There are more complex needs. The physical, emotional, and social needs of the patient were identified in this paper as being more complex. There are risks of worker injury, and we'll talk about that in a few slides. And there was a consistent failure to have size-sensitive equipment in place. Now, we will talk about sensitivity shortly because lack of equipment threatens sensitive care. So in summary of this slide, regardless, there are barriers that you face in providing care. Now, Cheryl and I have both written on sensitive care. And so from a historical perspective, I just want to take a quick look at your screen and to recognize that the full body was worshipped throughout time, but a lot has happened since the last 25,000 years when this image was created. But there has been a resurgence of this, but there still exists bias in general in healthcare. So we do know from a historical context when there are food shortages, then of course obesity is revered. We know that there are technological advantages in life, but we also know that those impact our level of activity. There is an abundance of food in the States right now, and food is delicious, and we love to eat food, and that of course lends to risks for obesity. However, that is not the only etiology of obesity. And, now we are really looking at the self-acceptance movement. So there's just a lot happening from a historic context around sensitivity, but what we do know is there's bias in general. Now, I think in order to address this topic, it's really important to acknowledge the work of Rebecca Puhl. Dr. Rebecca Puhl has conducted research on weight bias for more than 20 years. She's published numerous studies on weight-based bullying in youth, weight bias in healthcare and the media, interventions to reduce weight bias, and the impact of weight stigma on emotional and physical health. And I suggest if you're viewing this presentation as a resource for creating your own training, really look to Rebecca Puhl as the foundational leader for sensitive care. So, in addition to Dr. Puhl's work, keep in mind there are a number of models used to train sensitivity. Studies show that, unfortunately, nurses and other healthcare professionals also have strong negative attitudes and reactions toward people who are obese. So this research helps indicate that there is a pervasiveness of social stigma around obesity. Evidence also reveals that when obese patients are confronted with prejudice and discrimination in healthcare, it really leads to a reluctance to seek care or follow medical advice. So when we look to the future, we ask this question: how do we address the intersections of clinical care and sensitivity? And in a little bit, I'm going to talk about the work of Kaminsky and others who really looked at the relationship between having adequate equipment or having adequate training and policies and procedures and how that impacts sensitivity. So I agree with other researchers that insensitivity is born out of our inability to provide reasonable care. So let me ask you a question, because I want to talk about the physical tasks that I want to talk about the physical tasks that you conduct each day. And so I'm going to ask Monica to help me, because I want to do the second poll. And so Monica, can you get on the screen and help us with the second polling question? Okay, so Monica is telling me that the second polling question is up. I don't see that on my screen, but that's no problem at all. So the questions that the polls are going to ask you is, what is the most difficult task that you perform in caring for your patients who have obesity? Is it the boost in bed? Is it the chair-to-chair transfer? Is it pronation, or is it toileting? So I'm going to let you take a few minutes to do that. And while you're doing that, I'll just kind of talk through some of, not to give it away, but to kind of talk through some of the issues that we see around caring for our patients who have obesity or do not have obesity. And we do find that the boost is probably one of the most dangerous procedures because we do it all day and many times we do it unassisted. So with that said, I'm going to go ahead. Let's see. So Monica is helping me here. It looks, and you see this, that you agree with that. 23% of you indicated that the boost was the most difficult. 11% said chair to chair. 21% pronation, and 44% of you indicated that toileting is the most dangerous, most difficult physical task that you perform. So this kind of information helps you in terms of, you could even do a similar poll in your organization to identify the high-risk, high-frequency tasks where you could make a difference. This slide that I prepared for you, in my opinion, what you have responded very much follows what we see. But let's just look at this for a minute. The boost used to be the number one, and right now I think pronation is really high on individuals' perspective in terms of dangerous tasks. And this word cloud that I created is based on data that we have collected in the past, and it's not that much different than what you shared with us today. So I want to talk a little bit about the science of occupational injury that's associated with caring for patients who are obese. And in this landmark multi-site study that you see referenced here that was done in North Carolina by Walt Porres, Dan Drake, and others, the findings suggest that when caring for patients with a BMI greater than 40, manually handling those patients, that represented 27% of all repositioning injuries in that study period, 36% of all turning injuries, 37% of all lateral transfer injuries, and 30% of injuries related to ambulation. So you can see that there is a realistic fear of injury. Also in the Worker Safety Toolkit that's published by the Association of Operating Room Nurses, it was reported that back injury is the most prevalent injury among nurses. So you see the reason why we're hesitant to care for individuals who are obese is that realistic fear of injury. So what we find in organizations is that many healthcare workers are concerned about occupational injury associated with lack of equipment and technology. So Cheryl's going to share a lot with us about this in more detail in just a minute, but I just wanted to share some issues with you. Regardless of the type of equipment that you're evaluating for caring for your larger patients, it's important to consider whether the equipment or the technology would accommodate your patient's weight and weight distribution. For example, to ask the question, not only what are the weight limits on the equipment, which are important because working loads cannot be exceeded or the equipment will break or will malfunction, but what is the patient at his or her widest point, which might be hips, abdomen, the feet, and can the equipment accommodate this weight distribution? And we talked about the abdominal pannus, but most people who have a large abdominal pannus or girth breathe better in a semi-reclined position as compared with a high Fowler's position. And therefore, reclining positions are preferred, especially when we're talking about wheelchairs, etc. And this is one more example, and then I'm going to turn it over to Cheryl, but when the patient has a protruding buttocks, his or her center of gravity when sitting on a chair or wheelchair is forward, and that can lead to falls. And the last thing I want to say in terms of foot placement, footwear, and foot pain, these can all impact standing, walking, pivoting. So equipment that accommodates a walking device, whether a walking sling, support, sit to stand, or a simple walker, must accommodate the person's not only their weight, but their body distribution and other limitations. So with that said, we really want to hear from Cheryl, so I'm going to start with a question for you, Cheryl. Is proper equipment mandated? And if yes, by whom? Cheryl.
Thank you so much, Susan. And yes, proper equipment is mandated. Legislation, research by individuals and organizations have led to many changes in healthcare. The Americans with Disability Act is a comprehensive piece of civil rights legislation that prohibits the discrimination and guarantees that individuals with disabilities have the same opportunities as everyone else. A disability, which is defined by the ADA, is a physical or mental impairment that limits one or more major life activity. Employers and healthcare organizations are expected to make reasonable accommodation by providing the appropriate equipment and supplies so that individuals with obesity may manage their life activities. In order for bariatric surgery programs to be accredited by the American Society for Metabolic and Bariatric Surgery, also known as ASMBS, these programs are required to participate in the Metabolic and Bariatric Surgery Accreditation and Quality Improvement Program. Quality standards must be met with the primary goal of patient safety, which includes specialized equipment in caring for patients affected by obesity. And when we look at weight loss and metabolic bariatric surgery, is that individuals, if their body mass index is 35 with two conditions linked to obesity, or if their body mass index is 40 or greater, they would qualify for weight loss or metabolic surgery. And the American Society for Metabolic and Bariatric Surgery has partnered with the American College of Surgeons to address those needs of those patients. Through their collaborative efforts, they have established standards for high quality care. These standards are an objective and measurable means to ensure that centers are providing safe, quality care for patients from their initial surgeon consultation through the intraoperative process and long-term as patients continue their lifelong care with their surgeons. And some really key important things is that, as we've mentioned, the ASMBS standards have evolved to much more global application throughout healthcare. So for anybody that is affected by obesity, we need to look at their specific needs, not just individuals who are having bariatric surgery. Some examples of those requirements are as follows. We note, for example, that we see that extended capacity and lift transfer devices need to be available. Fixed systems with overhead tracking are increasingly being installed. CT scans and MRIs and other imaging equipment need to be assessed for weight capacity, but also for the size of the gantry. Furthermore, the quality of the diagnostic imaging needs to be considered when determining which diagnostic test needs to be ordered, as imaging can be distorted with the adipose tissue. The weight capacity of equipment needs to be labeled in such a way that direct care providers can easily determine if a piece of equipment meets patient requirements. Also, when we're looking at even the toilets, right? When we're looking at toilets, is that they should be floor mounted or make sure that they have the capacity to support the weight of the patient. When we look at grab bars and bathrooms, they should have the load capacity so they aren't pulled off the walls. Even the furniture in the lobbies and the waiting areas should be made to accommodate the larger patient. Also, when we're looking at exam tables, they need to be comfortably and able to safely accommodate patients. Also, operating tables must be sufficient for the weight and the width of the patient, while still being able to maintain full articulation. In our organization, we had to purchase sturdier straps to secure the patients for our surgery and our procedures. Elevators also need to have increased door clearance and weight capacity. Patient rooms are increasingly becoming larger so that they can accommodate the bariatric beds and other specialized equipment. And what's interesting about the beds is they are becoming much more diverse. They can include scales, and some beds have specialty mattresses for pressure release that can inflate and deflate in sections to help relieve pressure ulcers, since these patients may be harder to turn and reposition. We also have to look at bariatric gurneys and wheelchairs, and they have to be readily available. Communication is also very important when handing off patients from department to department.
So, Cheryl, I have two questions for you. You've talked about weight loss surgery, but let me ask, do you agree that whether the patient is admitted for weight loss surgery, general surgery, or for general medical reasons, accommodation must be in place? What's your thought about this?
Yes, Susan, accommodation must be in place for any patient who is admitted to an organization. As you mentioned, weight bias in healthcare is very common. Obtaining the appropriately sized equipment and supplies prevents worker injury and patient injury, but equally important is that caregivers feel prepared and are more patient when providing care if they have the equipment and supplies that they need. And also, patients have a much more dignified experience.
Yeah, I completely agree. So let me ask you a second question. If weight loss surgery care protocols are in place, are these different than general bariatric care protocols, Cheryl?
No, they are not different. Weight loss protocols were developed by clinical experts who understood the unique considerations of the patient affected by obesity, but they are applicable to any healthcare provider who is caring for these patients. The optimal care of these patients begins with understanding the unique psychosocial and physiological needs of these patients. Protocols can serve as a resource for caregivers in assessing, treating, and managing the care of any individual with obesity. Furthermore, protocols can lead to safe, effective, standardized care. Managing the care of these patients can result in fewer worker injuries and worker sick time, greater staff satisfaction, and staff turnover, all of which can have a significant economic impact and protect the health and well-being of healthcare providers. Protocols also serve as a guide to help organizations determine their requirements for equipment and supplies. The goal for care of bariatric surgery is wellness. Mobilizing these patients earlier and more often leads to improved health. Proper equipment and training in the use of equipment is essential in achieving this goal. At our organization, weight loss surgery protocols have led to putting together a team to develop an electronic medical record power plan. This plan is in process right now. Working with our IT team, the plan will pop up when the bariatric patient is admitted for any medical reason. It will assist caregivers in obtaining the appropriate resources, such as equipment for the patient. And next, we're going to be having Susan discuss the Kaminsky study.
Yeah, so Cheryl, I appreciate everything you shared, and there are a lot of takeaways on that, but I do love the idea that you're looking at, accommodation among all patients irrespective of their service line and protocols, and then having that put together in an IT mechanism so that that can be triggered and then care can be, put in place. And so we're going to talk about that in a few minutes. I do have 3 studies I'd like to share with each of you, and I'm going to go through them very quickly because we want to make sure that we have time for questions. But the first one is the Kaminsky study, and this was, I thought this was a very profound study. You can read what's on the slide, but what the authors found is that units without proper equipment and training had more unfavorable attitudes toward obesity. And so I use this study a lot as a reference because it really does help readers understand how important it is to have reasonable accommodation, because as healthcare workers, we want to do a good job, and if we don't have that, it impacts our attitudes toward caring for certain patient populations. The second study I want to share with you is the Temple study, and this is the pre-planning study I promised you I would share with you. This is a study that's downloadable and free of charge, and I would encourage you to access this through Bariatric Times. It's also referenced on your slide. I just want to quickly go over this. This had to do with a case in New Zealand, and it has to do with one gentleman, 2 admissions 18 months apart. There were similar admitting diagnoses, but the first admission he had an extended length of stay, and so he did delay hospitalization as long as possible. On the first admission, he was seen on day 8 for therapy. On the second admission, he was seen on day 1. You see, a pre-plan had been put in place during those 18 months that he had been at home in between his 2 admissions. On the first admission, he was discharged after day 80. On the second admission, he was discharged on day 13, even though he was sicker. On the first admission, the cost was for his care was over 98,000 New Zealand dollars, and on the second admission, it was 33,000. There was profound decreased length of stay, profound cost. I would encourage you to access this article for justification for pre-planning. Now, the next article, we were hoping Cheryl and I could kind of talk about back and forth, but we're going to refer you to this, download this. This is a wonderful experience that Cheryl had. She brought this opportunity to us, and we were originally asked to talk about weight loss surgery and critical care. And we asked the publishers if we could go ahead and do a paper on general care of the person having weight loss surgery or any other reason for hospitalization. And you can see listed on the screen here are some of the topics that are covered in this manuscript. And I would encourage you to get onto this or even to ask either one of us questions about how this was handled. Now, I do want to go through the next few slides just to talk about the purpose of this slide is to reinforce the reasons why we need pre-planning for care. So, don't ever miss out on the opportunity to make a difference for your patients, your organization, your colleagues, and yourself. Consider ways you can begin this journey toward better patient outcomes and how you can improve worker safety. Ask yourself this question: how do you make changes or integrate improvements into your practice by not changing workflow? Some ideas for success are to build a consistent plan of care and to understand pre-planning is key to reproducible outcomes. Use the tools and resources available to you and your team or other models that are already in place in your organizations to care for complex patients. Now, I'm going to go through this 4-step process. There are a number of ways to do it, but I like to do this. I like to have a 4-phased approach where we have our team, our protocols, our training, and our outcomes. All of this is published, and if you're interested in it, contact us and we can send this out to you. The value of an interdisciplinary team is that you bring diversity into the team, which is really important. And I've listed a couple of members that might be on the team, but keep in mind there could be many, many individuals who are ad hoc who support a team and can help make decisions around protocols. A criteria-based protocol should be in place regardless of practice setting, whether you're home care or clinic care. It really is pre-planning based on specifically designated criteria. Remember, we talked about those 4 criteria in the beginning: weight, BMI, weight distribution, and girth. Ask yourself these questions. Who develops the common, predictable, and preventable consequences of care? Where, when, and how do injuries occur? What equipment do you need to take care of those patients? What resources or experts do you need to take care of those patients? Then as far as training, you have the slide in front of you, but do a needs assessment. Find out what your clinicians are needing in terms of training, whether it's unit-specific or discipline-specific, and recognize the difference between education, training, and competence. When you look at outcome measures, we want to look at structured longitudinal data, and we want to look at data that reflects what your facility initiatives are. We want to ask this question: does what you do make a difference? So with that said, I do want to just briefly go through the summary that we know the prevalence of obesity is increasing among all groups. We do know that we have to understand standardized measurement and definition. Adiposity affects the human body in ways that impact the patient care that we want to deliver. Metabolic surgery is one method to manage weight loss in a healthy, sustainable manner. Equipment and technology support sensitivity, and pre-planning for care is designed to improve clinical, humanistic, and cost outcomes. With that, thank you. This concludes our presentation. I look forward to your questions, and now I will turn the program back over to Rhonda Turner.
Thank you so much, Susan and Cheryl, for that most interesting, timely, and thought-provoking presentation. Fabulous information. Before we begin the question and answer session, I'd like to go over how to obtain your CE Directs. So again, you are approved for one contact hour. To obtain these CE Directs, you need to go to www.saxtesting.com/MHB. You'll need to register at the site and complete the evaluation before you can get your certificate of completion. So make sure you complete that survey. And again, thank you, Stryker, for providing the support for this educational opportunity. There will also be an archived on-demand version at www.better-healthcarenow.org. An email will be sent to all registrants when available, and this online or on-demand version will be accredited for nurses and respiratory therapists. So with that, we do have quite a few questions, so we'll go through as many as we can. This one is for both of you, Susan and Cheryl. We always think sustainability, but the question comes from Evelyn. How can we go about guiding patients that have had bariatric surgery 10 years ago with excellent results into the same mindset that they had prior to surgery? So how do we enhance that motivation, and what are the tools being used?
Cheryl, I'm going to let you answer that question.
Certainly. Hi, Evelyn. One of the things that we try to do is we want to make sure that we have ongoing support with our patients. So one of the things that we do is that we also look at having support groups. We want our individuals to continue coming back to see their bariatric surgeons. And you're also asking about any studies that have been done to correlate high incidence of female alcoholism. And what we do is we do educate our patients about that increased risk. We try to discuss that with them preoperatively. But that's the reason it's also important that they do have a psychological evaluation. We want to make sure that if those issues are, we notice that there's a concern about that they get in touch with some of the individuals that did assess them before surgery. But also we have the behavioral specialists that also can help identify individuals if they need more intensive care.
Well, that segues great into the next question, especially with our COVID season. What is your approach in ventilating a patient that is obese? And it comes from Donnie. I think Cheryl would be a good one for that.
Yeah.
So, we have to think about the ventilator settings. And so we know that with the pulmonary specialists really need to make sure that there's not too much airway resistance. We know that it can be problematic. And so, again, we have to make sure that we don't have too much pressure. We have to be extremely aggressive in pulmonary care because obviously the weight of the chest certainly can increase their risk for atelectasis as well as pneumonia. So, again, it's just really great pulmonary care.
Yeah, and I want to add, and I think Rhonda Turner would say the same thing from a safe patient handling perspective. Sometimes we don't put those two together, but wow, the equipment has to work properly. You have to be able to make sure that the head of the bed can be elevated because we don't want to have the abdominal tissue displaced up to the thoracic cavity because that, of course, can lead to problems. There can be problems with aspiration if the patient can't be in the proper positioning. And we were just on a situation where the patient was placed into a floor-based lift with a walking sling. And so even though, we don't think of ICU rehab or progressive mobility in the ICU, that really did help turn around this patient's respiratory function early on in the ICU experience. And I think that's key, is to be as aggressive, as you said, Cheryl, aggressive in terms of a pulmonary perspective, but also the whole body to reduce those hazards of immobility. So I think that's a great question. And that in itself would be an hour-long presentation. Don't you agree, Cheryl and Rhonda?
Exactly. Yeah,
definitely.
Yeah, a lot of great stuff. Another question for us?
Now, Susan, I know this one is very near and dear to your heart. Where do we go from here, or how do we start to make a difference?
Yeah, so, sometimes it's that one patient. See, that's what happened in New Zealand. It was about that one guy, and they felt like they didn't do a very good job. And so they put together a criteria-based protocol, and then he came back again, and his care was completely different. Sometimes it's taking advantage of that one situation that happens. Without that impetus, start talking with like-minded people who are interested. Keep in mind, administration won't always be on target with this, but first step is to get that interdisciplinary team and make sure that they're advocates for patients, or maybe even to have a previous patient or someone who is of size who can help you talk it through. So even though we quickly went through those 4 elements, start with that team and have like-minded people get together, and then start with your protocols, your training, and make sure everything meets the actual needs of your healthcare workers and your patients. So thank you for that question. Really short answer, but I think that you can always reach out, if you have additional questions on that. But thank you. Yeah, that is near and dear to my heart.
Excellent. We're hitting the 2-minute mark. It's 10:57, and I have one more question I'd like to ask. What diet plan should be used for an obese patient?
So may I start with that question, and then I'll have Cheryl follow through with that. It's more than a diet plan. Sometimes we think, and I don't think we touched on this properly within the context of this presentation, but it's not as simple as calorie in, energy out. There's so many other factors. So as far as the diet, I don't know. I don't know what I think about that. But what I do know is that when the patients come to us, we want to care for them. And we want to do the best job that we can for them, and to recognize that obesity is multifactorial. And even when we think of that very first question, I agree with Cheryl that really needed to be a reassessment, not only the emotional but the physical reassessment. There are many factors associated with obesity. So I think the issue is not necessarily diet. You don't want to hear that. That's not really responding to your question, but it's really multifactorial. Cheryl, what are your thoughts about that? You don't have to agree with me.
I do agree with you, Susan, and that's one of the questions that is often, I'm approached about. And it is so multifactorial, you really have to look at the individual. There's not just one answer, a specific diet. We've had multiple speakers at the Sharp Healthcare Obesity Crisis Conference coming in and talking about that. And it's really looking at the individual and seeing what is some of the challenges that they're experiencing, both emotionally, their environment. And so it really takes a total assessment before you can really come up with a plan of care.
Thank you, guys. We are running out of time, and I just want to thank all the participants for caring to show up and get gain knowledge in this area. And I'd like to turn the presentation over to Monica for concluding remarks.
Thank you. And this does conclude our webinar for today. I'd like to remind the audience that there is a survey for you at the conclusion of this webinar. It will pop up immediately, and we greatly appreciate you sharing your opinions on today's webinar. We do value your opinion. And thank you again on behalf of our presenters, Sachs Healthcare Communication, our sponsor Stryker. We hope you enjoy the rest of your day. Thank you so much.